about redesigning the clinical trial and really the role wearables has in that process. I'm part of the innovation team in ICON, and although we sit in the IT function, it's actually quite an unusual group of people. So we have people who are data managers, data architects, people who are involved in wearable technology, some ECOA experts, and people who are experts in the area of kind of user experience and design. So we feel we complement the aspects needed in terms of looking at new ways of the problems in the clinical trial process. And there are problems in clinical trials. I mean, everybody knows that the pharmaceutical industry and the current process of bringing drugs to market is, if not broken, in need of repair. It takes way too long. It takes something like 13 to 15 years for a drug to go from discovery through to the market. And that only gives another kind of 7 to 5 years for the drug companies to make any revenues. It costs up to $3 billion to bring a drug, and a significant proportion of drugs that are discovered actually never make it to market. And so the process is way too laborious, way too cumbersome, and it's becoming more and more difficult for patients to access the therapies and treatments that they need. And so with the clinical trial team in ICON, we have this approach around this D2P. I'm afraid I'm going to press the wrong button here. I'll point. This D2P process, which is kind of direct to patient strategies, to see if there's some way we can change the design of the clinical trial. And within ICON, we've taken an approach that we've divided this D2P process, this direct to patient strategy, and we're looking at things like ECOA. And for those of you not in the pharmaceutical industry, ECOA is e-clinical outcome assessment. So you would have heard about questionnaires earlier. You also have kind of clinical observation, and you have things like performance. So somebody asked to do a 6-minute walk, or to go up the stairs, or to get out of a seat. They would all be part of this ECOA process. We're looking at health outcome measures. So you would have heard perhaps some of my colleagues earlier talk about ICHOM. And that we're trying to look at things that are meaningful to the patient. And that feeds back into some of the things around the ECOA. So if you go into a trial, the 6-minute walk is a test that's used a lot in a clinical trial and in clinical practice. But how valuable or interesting is that to a patient? They don't care about a 6-minute walk. They might care about taking their kids to school. They might care about being able to walk again. They might care about going to the shops. But so trying to, again, understand things that are important to the patient is really, really, what this is all about. And then we're looking at some apps. So, I mean, you may have heard of the Roche app for Parkinson's disease, where they're using a phone to collect some data. We've also developed some apps ourselves as part of connecting and talking and reaching the patient in new and different ways. And one of the issues, and we've talked about the cost of a trial, and we've talked about kind of, the regulatory process and the logistical differences. But one of the key components of running a trial is actually recruiting patients. And when you have recruited them, actually keeping them in the trial, that's a big, big issue for clinical trials. And so patients join a trial for different reasons. They have altruistic reasons. They want to do something. They want to give something back. Sometimes they want money. There's a lot of professional patients in the US particularly who actually get reimbursed for being part of a trial. And you've also patients who feel that being part of a trial will give them access to treatments and therapies that they wouldn't normally get. So they're the kind of motivating factors. And then balancing that is this notion of burden. How difficult is it to be part of a trial? So you can imagine, if you live in Kerry and there's a trial on in James's Hospital, and you're supposed to come up once a month, and you have Parkinson's disease, or you have some other disease that impacts your ability to move, can you imagine the difficulty of getting from, even if they pay for it, but getting from Kerry to James's, getting parking, getting somebody to come with you, going in, it's really, really difficult. So being part of a trial actually is difficult for patients. And then they're asked to do a whole series of tasks. And they might have, 3 or 4 different devices with different questionnaires when they go home. Or they might have to take 4 pills a day and 5 pills the next day. And so it can be extremely complex. And so that is always balancing against their motivation. And that's why sometimes patients drop out, because they're just too difficult to be part of the trial. And so what we're looking at is, how can we use wearables to actually balance that burden a little bit more? But also to look at things like getting different types of data. So when they go into a clinic, the clinician will sit there and they'll do the test. Now, none of you have met my mother. My mother goes to the doctor and she complains for months before you eventually get her to go to the doctor. When she goes to the doctor, what does she say? Oh, I'm grand. There's nothing wrong with me. I'm perfectly fine. Walk the line. And she will walk the 6, and she will get there, and no matter what. And she can't even walk across the kitchen, And so the snapshot in the clinic is not necessarily representative of what's happening in a patient's home environment. And so when you're trying to assess if your drug is making a difference, and every time, the patient goes into the clinic and they're, nope, I'm grand, there's nothing wrong with me, look, I can walk down the road, because they want to please the doctor. You don't know what's happening. Whereas in the home environment, if you were collecting the data, you might actually be able to see something that's more responsive. You might be able to collect the information to see the incremental improvement and to understand if your drug is making a difference. Because if somebody goes in to the clinic and is behaving exactly the same way, I can do what I can do, you can't see the difference. And it's those observations that actually feed into the endpoints. So the drug could fail, purely because the subjective measures are not capturing real objective change. And that's one of the big positives of having sensors in a home environment. But you also can increase patient engagement, because you can respond to them, you can send them messages, you can say, well done, there's lots of this gamification happening now, where you're encouraging and rewarding patients with notes to say, fantastic, 6 hours dedicated, 7 days dedicated to research, 48 days, and those things are motivation. You can reduce the burden of travel to the site. You can look at new endpoints. So suddenly you're collecting the subjective data in the whole environment, and you can start seeing if there's different endpoints that are more clinically responsive than the ones that you currently have. You can look at more robust screening. So when somebody comes into the trial, you can actually check them more thoroughly prior to engagement. You can have this more flexible, adaptive trial that my colleague Doreen was talking about earlier. You could have improved data quality because you've objective rather than subjective. And this isn't to replace the role of how the patient is feeling and what the patient is thinking and how they perceive their disease and their improvement, but it's trying to get underlying objective data to support that. And while I'm saying here, it's reducing patient burden, I'll talk to you, hopefully if I don't go over, which I might, about one of the apps that we have for looking at patient observations in a trial, because one of my fears is that we will simply load somebody with loads of sensors, leave them in their home environment, completely unsupported, and actually we're not reducing the patient burden, we're merely shifting the patient burden. And I think that's something that also has to be managed very carefully. And in terms of where we are today, there's lots of companies looking at this, and some companies are a little bit more advanced than others. Pfizer, Novartis, GSK, Sanofi and Teva tend to be ones that are leading the charge in terms of trying to improve and trying to look at this area. The Pfizer remote study from 2011 is probably the most famous one that's out there. I mean, it was a failure of sorts because they couldn't recruit, but they put in place processes that other companies are building on. So it was a very brave thing to do, and they really have encouraged other companies to enter into it. Teva and Intel, actually I don't have Roche up there, which I should have. Teva and Intel are doing a collaborative project on Huntington's disease that was in the press recently, where they're using a watch and an app on a phone to collect data from those patients. Roche have done a huge project around Parkinson's disease, where they're using the phone not only to kind of interact with the patient, but they're also collecting information about the patient's voice and also the movement, using the gyroscopes and the sensors in the watch to actually collect that data. So again, it's around this real life, continuous streams of clinical data. And we were actually part of the mHealth Grand Tour in 2015, which was actually a diabetes race. So it was a cycle using type 1 diabetics. They went from Brussels to Geneva, and their 5 minutes, and their clinical data was actually collected en route. So their heart rate, their blood glucose, their weight, all of that was collected as these guys cycled from Geneva to Brussels. We sponsored a cyclist, a gentleman by the name of James O'Reilly, a type 1 diabetic. He's a fantastic story, he's a fantastic advocate. But that was part of this process. Could we run a clinical trial in the wild? And it was a really, again, there's always lessons learned in these projects. So there are companies really looking to see if they can have these remote and these virtual trials. Sanofi, although there was no drug intervention, sponsored a trial where patients were recruited with Facebook. And actually, the age profile of those patients were in their 60s and 70s. So again, age isn't necessarily a barrier to technology. So it is moving on apace. This is an app. We're part of, I don't know if anybody here is from ARCH or knows of ARCH, so the Applied Research. Okay. So we're involved with a project in ARCH where we're looking at collecting data from patients in a nursing home setting. And really this idea of place shifting. So can we run a clinical trial outside of a traditional clinic? And obviously if you're running a trial in frailty and sarcopenia, an elderly care home is a good site for that. And it's not really, it's not an interventional study, it's really observational. So we have an app where, we ask questions about how they're feeling, etc. But actually the real reason and rationale for running the study is to look at burden. Is it burdensome for older people to be part of the study? If they're in a care home, will they feel stigmatized by being part of the study? Are the people who are running the study for us in the care home, is this a burden on their daily activities and how they go about their daily lives? And so it's really not just about technology, but understanding burden, and is this feasible to run it? And I mean, if it is feasible, it actually would be, I think, a fantastic way of designing a trial. So you bring the trial to where the patients are and not actually have them come to the centre. And that, we believe, is going to be a huge advantage. This is just another project we did. I won't go into it in any great detail. There are other people doing the same sort of thing, using the Connect to see if it has, clinical relevance. But this, we believe, to be the future. And this is my final slide. Where you actually look at the patient and look at the various clinical indications, and then you group a variety of different sensors, including questionnaires, and you take that data. So the data travels, but the patient stays where they are. And that, we believe, will help enrich and reduce the burden on the patients. We're a long way to go, but we're getting there. And that's, I think,